Welcome to our MyIBD Learning virtual program, Bridging the Gap from Pediatric to Adult Care. My name is Kagan Ellis. I'm a 21-year-old ulcerative colitis patient, patient advocate, ostomate, and Crohn's and Colitis Foundation NCCL member. Navigating from pediatric to adult care is an important process for children and teens with IBD. We hope tonight you learn how to empower our young patients with the knowledge, skills, and independence to care for their IBD as they enter adulthood. In order to make the program more interactive and find out how much you've learned tonight, we'll be asking 2 questions via a poll on your screen now. Number 1, which of the following is a possible reason for transitioning medications as a patient moves from pediatric to adult care? And number 2, which age group tends to have the poorest disease management? I'll give everyone a few seconds to make their selections. And at the end of the presentation, we'll ask these questions again and see how much the group has learned. Thank you for your participation. It looks like most people selected all of the above for question number 1 and teenagers for question number 2. Let's listen in to the following presentation to learn more. On behalf of the Crohn's and Colitis Foundation, thank you all for joining. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. The program will be recorded and posted on the MyIBD Learning website, www.crohnscolitisfoundation.org/MyIBD Learning, and everyone who registered for the program will receive a link with the recording next week. We want this to be as interactive and engaging for you, so we encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists and will address as many questions as we can at a time. Tonight, we have the opportunity to hear from a pediatric gastroenterologist and licensed psychologist. Our first presenter will be Dr. Amanda Wenzel. Dr. Wenzel completed her pediatrics residency at Children's Wisconsin in 2017, followed by a gastroenterology fellowship at Ann and Robert H. Lurie Children's Hospital of Chicago through the Feinberg School of Medicine in 2020. She then spent 2 years as an attending physician at Lurie's Children's before returning to Children's Wisconsin, where she currently practices. Dr. Wenzel is passionate about counseling her patients with inflammatory bowel disease and empowering them to make informed decisions about their care, especially in a field with expanding treatment options. Our second presenter is Dr. Melanie Birnbaum. Dr. Birnbaum is a licensed psychologist who is board certified in clinical health psychology. She spent her career working with children, teens, and young adults with chronic health conditions. Dr. Birnbaum trained at Johns Hopkins School of Medicine / Kennedy Krieger Institute and has been on faculty at Cincinnati Children's Hospital and Phoenix Children's. She specialized in the treatment of patients with GI and neurological conditions. She founded her private practice, Scottsdale Pediatric Health Psychology, in 2015 and has transitioned to doing this on a full-time basis. We understand the importance of your questions and want to ensure we answer as many of your questions as possible. Tonight, we have the honor of having Charlotte Rensberger monitoring the Q&A box. Charlotte Rensberger has been in pediatric nursing for more than 20 years and has been an advanced practice nurse since 2013. She has been working as a nurse practitioner in pediatrics gastroenterology since 2022. Diagnosed with Crohn's disease as a teen, Charlotte's passion for patients with inflammatory bowel disease and other chronic gastrointestinal illnesses and conditions runs deep. She has an interest in the process of assisting teens with IBD through their transitions to adult practices, nutritional strategies for IBD patients, and also helps patients undergoing ostomy surgery. If you have a question for Charlotte Rensberger, please type it into the Q&A box. She will do her very best to answer as many questions as she can, keeping in mind that she may not be able to address every question. Following Dr. Wenzel and Dr. Birnbaum's presentations, Charlotte will join them for a live Q&A session. Listed here are our speakers' financial disclosures. Now let's get started with tonight's presentation. At this time, I'd like to welcome our first presenter, Dr. Amanda Wenzel.
All right, thank you, Kagan, and thank you to the Crohn's and Colitis Foundation for inviting me to speak. My portion of the talk is called Growing Up with IBD. So the goals of this talk are to understand why medication changes may occur, prepare for common adjustments in medications that may occur as patients transition from pediatric care to adult care, and highlight best practices for continuity of care. Next slide. So there are differing approaches to care between pediatric and adult side. While pediatrics is in a focus on, the family, and there is heavy parent and family involvement and choices about IBD care. As patients transition to the adult side, there is more of a focus on the individual. The patient has more autonomy. It is more disease-centered rather than developmentally centered. So there is quite a transition that happens in the type of care that is provided. You can see at the bottom, I put a picture of our pediatric center and one of our adult centers, and the vibes are different. So it can be quite a transition, and medications are part of that as well. Next slide. I think also it's important to highlight that there is definitely a shift in treatment goals. Much of what I speak to my patients about on the pediatric side is really about getting them to adulthood. So things like growth optimization, getting patients who are pre-pubertal through puberty, developmental considerations in patients who are very sick. There may be, developmental and psychosocial concerns. Bone density is a really big topic in our pediatric patients, especially patients who may be on things like chronic steroids, and trying to preserve medication options because our patients are being diagnosed as pediatric patients. They have a longer disease course ahead of them. And so we try to do whatever we can to keep those medications options open as they become adults. While in adult care, you're finishing up some of these things like growth optimization, for example, the treatment goals differ. We're talking more about medication administration. So when patients go to college, do they, prefer something more sub-Q or oral versus IV infusions? Sexual functioning and fertility and pregnancy sometimes come to mind as patients, get into their early to mid-20s. Preventing, long-term risks of malignancy and then risks of long-term immunosuppression. So there definitely are differing treatment goals on the adult side. Next slide. So why might a patient's treatment plan change as an adult? For one, there are changes in disease behavior and severity. Side effect considerations. All medications have different side effects, and if there is a side effect to one medication, it may be worth transitioning to a different medication class. There are always emerging therapies. We've seen this in the last couple of years. Most of them are in adult care and not as much used in pediatrics, and/or adult providers may be more comfortable in using some of these emerging therapies. There are definitely differences in medication availability, both from an insurance and from just a general standpoint. And then again, insurance coverage and formulary differences may dictate changes to other medications. Next slide. So I came up with several key medication transition scenarios that I think it's important to know about as patients transition from the pediatric care to adult IBD care. One of these is combination therapy. We'll talk about de-escalation. Biosimilars are more common now, but we'll touch briefly on that. Novel IBD therapies, other mechanisms of action of other medications, other than kind of like the typical or longer standing IBD medications. Talking about newer medications with different routes of administration, and then finally touching on pregnancy. Next slide. So what is combination therapy is the first thing we'll talk about. Next slide. What is it? So many patients, many of you may be on an anti-TNF biologic. I didn't define that, but that is typically either infliximab or adalimumab. Either an IV infusion or an injectable. And combination therapy involves those medications with an immunomodulator. So these would include azathioprine, 6-mercaptopurine, or methotrexate. These are often used during induction or in patients at high risk of losing their response to their anti-TNF medication. So the immune modulators are used to protect, quote unquote, the anti-TNF biologic to allow for that durability of that drug in the long term. Why do we use combination medications? Again, it reduces the risk of anti-drug antibodies. One of the risks of anti-TNF medication is that your body can develop antibodies against the medication and make it no longer useful against your disease. So adding immune modulators is a common practice in adult IBD care that allows for protection of that medication. It does and has been shown to improve drug levels. So if your drug level is low, that is a common scenario in which an immune modulator might be added. It can enhance clinical and endoscopic remission. These medications, these immune modulators and methotrexate have been used for a long time for IBD care as single therapy, but in combination therapy, it's a second mechanism of action that may allow you to get over that hump and get to that endoscopic and histologic remission that your IBD doctor is so wanting for you. And then, combination therapy is really supported by a large adult trials. I listed a couple here. We don't need to go into them in detail, but just to know that they are, it is established as a treatment option. Next slide. There are, however, some safety considerations with combination therapy, and I think that's important to know as well. Obviously, with added immune suppression, there can be an increased infection risk with combination therapy. And then the thing that we counsel our patients on very seriously is the very rare but serious risk of a specific type of lymphoma called hepatosplenic T-cell lymphoma. We know that there's specific criteria that put you at higher risk for this malignancy. And so, we really counsel our patients on who is the right person to do combination therapy. And it's always a risk benefit of, getting your disease under remission and protecting that, the durability of the drug, as opposed to, the potential for malignancy, which the overall rate is very low. You can see some of the risk factors listed here. And then we do obviously tailor our approach to based on disease severity, tolerance of combination therapy, and your response to therapy. Oftentimes, that's not a long-term treatment option, but we do use it often in the short term, especially on the adult side. Next slide. So I wanted to highlight that this has been studied in the pediatric realm as well. This was a combined study looking at the effect of oral methotrexate and anti-TNF therapy in combination. And again, this is specifically in pediatric Crohn's disease. Patients starting either infliximab or adalimumab, and then they were randomized, so randomly assigned to either receiving methotrexate along with their anti-TNF therapy or placebo, and then they were followed for 1 to 3 years after the initiation of that. And they looked at risk of treatment failure with methotrexate, with infliximab and adalimumab. And among patients with injectable anti-TNF and adalimumab, but on infliximab, patients with Crohn's disease who were also treated with methotrexate in combination experienced a twofold reduction in treatment failure with a fairly tolerable safety profile and no increased risk of malignancy. So it is a safe and effective treatment strategy that we do sometimes use in our pediatric patients as well. Next slide. So next, I'd like to talk about de-escalation of therapy. I think this is a big topic on a lot of people's minds as soon as they start their Crohn's therapy. One of the first questions I always get is, when can I stop my therapy? So to talk about aminosalicylates and UC, so Lialda, mesalamine, sulfasalazine, in general, 5-ASA medications like that should not be discontinued. Overall, there's a low risk of adverse events with 5-ASA therapies. They're daily oral medications, and there is some research to suggest that they are protective against colorectal cancer. There was one study looking at the benefit of continuing it, and at 1 to 2 years remission, that continuing that Asacol over placebo does seem to help. That didn't seem to be a benefit after 2 years, but that study number was very small. So in general, there's not enough evidence to suggest that you should stop. Mesalamine maintenance treatment, according to ECHO, which is the European group or Crohn's and colitis group, mesalamine should be continued long-term. Next slide. So you can consider dose reduction, however, of 5-ASAs. If you're taking 4 pills of Lialda a day, sometimes we can reduce that dose a little bit and make it a little bit more tolerable for you. It can be considered in the right patient. If the patient has a high adherence to their medication, they're taking it daily, they're not missing many doses. They have a relatively mild clinical course with no flare-ups. We've checked their fecal calprotectin, so their stool test, to make sure that there's no residual inflammation, and oftentimes we will require a repeat scope to ensure that they're in remission before de-escalating their therapy. Next slide. What about anti-TNF dose reduction? Again, one of the biggest questions I get is, can I stop my infliximab? Can I stop my adalimumab? And there is some evidence, behind why we say no. I don't want to go through all of these studies in detail. You can see that the STORY study in 2012, so nearly over 10 years ago, almost 15 years ago, they looked at anti-TNF dose reduction, and nearly 50% of patients relapsed at 1 year after taking off their infliximab or adalimumab therapy. There are some risk factors for who might be not the right candidate. Males who have higher CRP, lower hemoglobins, and higher stool inflammation tests tend to have higher risk of relapse. And then the most recent one looked at infliximab withdrawal or immunomodulator withdrawal. And it looks like, as you can see on the right, looking at, how many patients had a flare, this green line shows you infliximab, and many more patients, when they discontinued their infliximab therapy, had a flare, as opposed to the immune modulator patients. Those patients tended to, not flare up when we reduce their immune modulator versus the patients who were, just in the continuing in the combination group. So it generally is safe to de-escalate your immune modulator, but in anti-TNF, we usually continue. Next slide. And then I won't go into this in detail either, but there is a study looking at, again, looking at the risk of relapse with immunomodulator withdrawal versus continued combination therapy, and looking at the risk of adverse events. You can see that on the top. And, patients who continued on combination therapy had, low risk of serious adverse events, and the patients who had immunomodulator withdrawal had similar risk of relapse. As opposed to anti-TNF withdrawal, those patients relapsed much more than continuing combination therapy with a similar risk of adverse events. So again, more evidence to say immunomodulator de-escalation, fine, anti-TNF de-escalation, usually not okay, higher risk of relapse. I do want to touch on biosimilars. Many patients may already be on these, but I think it is important to highlight because insurance is changing all the time. So what are biosimilars? Biosimilars are a drug that is very similar to what we call originator drugs. So for infliximab, for example, that would be the brand name Remicade. There are many biosimilars to Remicade, including Evolsa, Renflexis, Inflectra, et cetera. It is important to know that approval of a biosimilar goes through a very rigorous process. They have to work the same way as the originator medication. They have to be as safe as the originator medication. They have to be as effective. So they go through many studies to get to the point of being approved. There are many biosimilars available on the market to infliximab, but also adalimumab, and now ustekinumab, which is brand name Stelara. Next slide. Why switch to a biosimilar? Most of the time, it's a change in insurance coverage. It's very common. And I think that's important to highlight in transition because many patients, although they continue on their parents' insurance at the point of transition, there is some point in their early 20s at which they are likely going to have to transition to their own insurance coverage. And that may dictate a change to a biosimilar or from one biosimilar to another. Again, insurance always changes, and so there's always a chance that when the next year rolls around that your insurance may not cover the same biosimilar, so you may be switching to a different biosimilar. And then again, potential cost savings of biosimilar versus originator or from switching to one biosimilar to the next. Next slide. Again, this study is just to highlight that it is safe to switch from originator to biosimilar and from biosimilar to biosimilar. The study looked at patients switching from originator to biosimilar and looked at patients with 1, 2, and 3 switches. And they compared their clinical, their lab tests and their stool tests. And most patients, the vast majority, maintained their remission and had same side effects safety profile with multiple switches to different biosimilars. So it has been proven to be safe. Next slide. I think the crux of, transition is always the possibility of novel therapies in adult IBD that are not available or as available to pediatric patients. So I did want to touch on those. I think it's important to look at the timeline too. We've come a long way since the advent of infliximab and adalimumab over, in the early 2000s. If you look into like the mid 2010s, that's where, vedolizumab or Entyvio, ustekinumab or Stelara took wing. Tofacitinib was soon after, and now we've really seen an explosion of IBD medications. Sometimes it's hard to keep all of these treatment options straight, even as a pediatric gastroenterologist. Next slide, please. So I did want to touch on a couple of very common ones that have been used for a long time and may come up in conversation as a patient may transition to adult therapy. So the first is what we call anti-integrin therapy. That's the way it works. That medication is Entyvio, or generic name vedolizumab. It is administered via IV infusion, always IV infusion, and it blocks certain inflammation cells called lymphocytes from moving into the gut. It is a less immune suppressive due to gut specificity, so it's not as broadly immune suppressive as some of the other medications that we use, but the flip side of that is that it may take a long time to see effect. Oftentimes we're telling our patients, 3 to 5 months to really see a consistent effect. So in patients with more severe disease where we don't have as much time to wait, that might not be a great option, but it is a great option for patients who need a less immune suppression. There is also a sub-Q version available that we'll talk about later. Next slide. Next are the anti-IL-12/23 medications. There are 4 listed here that are being commonly used today. Ustekinumab or Stelara, risankizumab or Skyrizi, and then the newer kids on the block are mirikizumab or Umvo, and guselkumab, that's spelled wrong, sorry, guselkumab or Tremfya. These are all initially administered via IV in different numbers of infusions, and then after induction, then patient is transitioned to an injection. It blocks IL-12 and 23, which are inflammatory proteins that can cause some of the inflammation in some types of IBD. Risankizumab or Skyrizi in particular has an on-body injector, and I think that's important because it's different than some of the other injectables that we have. And maybe, a better mode of administration for some patients because it's applied to the body and the button is pressed and then it's self-deployed. There are some biosimilars available for ustekinumab, but not currently the other anti-IL-12/23. And then Janus kinase inhibitors are really the new kids on the block. Tofacitinib or Xeljanz was approved for ulcerative colitis in 2018. And then upadacitinib or Rinvoq was approved for ulcerative colitis and Crohn's disease. The advantage is it's a daily oral tablet. It blocks the Janus kinase signaling pathway, which is another pathway that we think may be responsible for inflammation in some patients with IBD. However, there are special considerations for these medications, and I highlighted some of them here. Acne is a huge one. We see that very commonly in our patients taking Janus kinase inhibitors. So sometimes in teenagers may not, especially teenagers with acne, may not be the best option. There are certain changes in lab parameters that we do monitor, both liver enzymes and cholesterol. And there is an important black box warning for blood clot risk for these medications. And so we always counsel our patients on that to make sure that they're the right candidate for this medication. Next slide. I think switching route to administration is an important topic in transition as well. Next slide. Why would we consider doing a sub-Q versus an IV medication? I think convenience is honestly one of the most common reasons why patients would think about switching to a sub-Q mode of administration. Many patients attending college, I think especially now that there are available sub-Q forms of infliximab and vedolizumab, I think that really transforms, the patient's college experience. Patients don't have to travel back home for IV infusions. They potentially, the right patient can transition to a sub-Q form and be able to administer it in their dorm room. Travel is another huge consideration, not having to to arrange IV infusions over travel, or if a patient is moving and they may be moving to a more remote location, may have harder access to care, may have trouble like establishing or need time to establish with a gastroenterologist, a sub-Q form may be a better option for them. Administration time is usually less with sub-Q. Patients can do it, around the time that they see fit, during the day. If they can't do it before work, they can do after work, et cetera, as opposed to trying to make a meeting or an appointment time for their, IV infusion. Many patients report an improved quality of life with being able to, administer their own medications at home. It can reduce healthcare costs with not having to involve an infusion center, and then resource utilization is huge. Next slide. So there are subcutaneous forms of biologics. Some of these are just subcutaneous in and of themselves. Adalimumab or Humira, for example, is one of the first sub-Q forms that we had. And then there are ustekinumab or Stelara, risankizumab or Skyrizi, and then Umvo and Tremfya. Eventually, all of those transition to a sub-Q formulation. And as I said, now as of 2023, in 2024, we have sub-Q versions of traditional IV biologics. So both infliximab and vedolizumab are now available as sub-Q forms. And then I did want to finish by touching on pregnancy with IBD. Next slide. Generally, it is considered safe to continue most therapies. I have a slide looking at different therapies and their safety and recommendations for continuing in pregnancy. It should be noted that procedures such as endoscopies are safe during pregnancy. Imaging is generally safe during pregnancy. So, anything that your, GI doctor recommends should always be a conversation if you're pregnant, but generally is considered safe. Some open surgeries can affect female fertility. I think that is important to know. Without going into too much detail, an open ileopouch anal anastomosis, just because there are female organs around where the surgeon is doing an operation, can sometimes be affected when patients do open surgery. We know a laparoscopic approach where patients have tiny little cuts on their belly and cameras are inserted, tends to be much better. And that's what most surgeons strive for if they can help it with IBD patients who need surgery. I think it's important to note that there is ongoing research in pregnancy and IBD. It's an often neglected point of research in the adult world that some researchers are trying to work on. The PIANO study, you can see, stands for Pregnancy and IBD and Neonatal Outcomes. They found in their research so far that active disease is more common than you see and can lead to increased miscarriage. Biologics can cross the placenta after 22 weeks. I think that's important to know as well. That's been studied, and it can be detected for a longer time after birth, several months. But as of late, there have been no adverse effects noted to fetus or newborn. Next slide. So I won't go into detail, but just to note that most medications in all stages of pregnancy are generally safe with a couple of exceptions. Number one is methotrexate. That's been long known to be a teratogen or a drug that can cause fetal birth defects. And then some of the newer oral medications for IBD are generally considered to not be safe for pregnancy. Those include the JAK inhibitors, tofacitinib, and Rinvoq or upadacitinib. And we didn't touch on the S1P modulators, but etrasimod and ozanimod are also generally considered to not be safe. So if you're, thinking about making a medication transition and you think you may become pregnant within a couple of years of that medication transition, I think that is an important topic to discuss with your gastroenterologist so that they can counsel you appropriately on what medications might be best for your disease and for your pregnancy and fertility concerns. So in conclusion, medications are common, but very manageable. We anticipate some of these changes and we try to help our patients plan to reduce disruption in their treatment and continue the remission or get patients to remission. And collaboration and communication between provider and patient is always key and is definitely key in this case as well. Thank you.
Thank you, Dr. Wenzel, for your presentation. Now I'd like to welcome Dr. Melanie Birnbaum, who will present next.
Okay, good evening, everybody. You can go ahead and go to the next slide, Kagan. So what I'll do today, I am a health psychologist, and a lot of people don't know what the heck that is. So I'll just give a quick overview as far as what that is. And then I want to talk about the process of transitioning to adult care because it is a process. I always say it's a marathon, not a sprint. So we'll talk a little bit about that. And then how to avoid what I'm going to call failure to launch. So being able to successfully get to adulthood and feeling like you have the skills and the tools to manage your IBD as an adult. And then also how to even access mental health support. Because I think a lot of people think, wow, that sounds like a great idea, but then don't know where to start. Next slide. Here we go. Next slide. All right. So, as Kagan, when she introduced me, I am a pediatric health psychologist. So we look at the interaction of biological factors, social cultural factors, and psychological factors as it relates to health and illness. So I and pediatric health psychologists, there are adult health psychologists too, but for me, I'll just talk peds. So they focus on treating children, teenagers, and young adults and their families as they're coping with and adjusting to having a chronic medical condition or injury. So we know lots of evidence-based interventions on how to help with this transition and how to help with managing your IBD long-term. And kind of one of the unique skill sets of health psychologists is a lot of us are embedded in medical settings. So we're used to collaborating and working with colorectal surgeons, gastroenterologists, dietitians, schools across the board. So in any event, that's kind of health psychology in a nutshell. Next slide. Role changes are so stinking hard. So if you think about, especially for kids who were diagnosed when they were younger, caregivers managed everything because that's what was developmentally appropriate. But as kids get older and they transition into being a teenager and a young adult, it's a struggle because parents are used to jumping in and answering questions for their kids. But part of the transition to adulthood is helping kids feel empowered to be their own historian, to give their history, to talk about their own symptoms. I also, having worked in medical settings as well, feel that a lot of times pediatric doctors, I've witnessed this more times than not, will come into a hospital room and start talking to the parent when you have a 17-year-old laying in bed, like the 17-year-old's not even in the room. So it kind of takes, I think it takes that awareness on everybody to say, okay, I need to speak to the patient directly. They are, capable of answering these questions, which brings me to the concept of scaffolding. Next slide. So Lev Vygotsky is a developmental psychologist. Well, I should say was a developmental psychologist. And he talked about this zone of proximal development and something called scaffolding. When you think about scaffolding, right, most people go to, that thing that stabilizes a building. But in this terms, as far as development goes, it's giving enough support to help someone achieve a task, right, or become competent in a task. So when we think of this zone of proximal development, this is really important. I do this a lot with my patients in therapy too. We create 3 columns: things that I know how to do completely independently, things that I can do with support, and then things I have no freaking idea what to do, right? I'm completely dependent on my parents for this. And that helps us see where we need to go with respect to managing my chronic health condition. So we think of learning to ride a bike. You start with training wheels, and then when the training wheels come off, maybe the caregiver holds the seat from behind and walks with their child. Then they run with them and eventually they let go, and guess what? The kid falls. But you know what? We're going to get back on and we're going to keep on going. And I know it's a weird parallel to draw, but managing IBD from a childhood to adulthood is not unlike that. There's going to be some missteps along the way, but it's much better to have those missteps when you have the support versus, oh, I'm 18, I'm on my own, I have no idea what to do. Next slide. Okay. So, love teenagers. It's my favorite age group to work with, but ooh, they do not have good disease management. So when we talk about adherence, it's how well a person's following their medical plan. And there are so many things that can go into adherence. it is very common for people with IBD to have depression or anxiety. If you think about it, I mean, IBD can be very unpredictable, especially in the early stages when they're trying to get, disease management, good disease management. So that can be very overwhelming. Sometimes depression affects motivation. Sometimes anxiety leads to avoidance. Oh my gosh, I think I'm starting to have a flare. I'm just going to pretend it's not there. And then that can result in a bigger problem down the road. Some of the side effects from the medications are not awesome. And then, even just feeling different from peers is another reason why people tend to avoid or not even want to deal with their IBD. And then shout out to Bandura, self-efficacy. He was the first psychologist to coin that term. That is, I have the skills, the tools, the confidence, and even the coping skills to handle what's thrown at me. And I'm confident that I can manage. There are so many things, like I said, that go into adherence. I'm not going to go into all of these for time's sake, but forgetting, I'm busy, I love insurance. It's screwed up my authorization, so I don't have it, so I'm out. So there's lots of different reasons why people aren't following their medical plan. Some may be intentional, some completely out of their control. Okay, so the bottom line is learning to manage your IBD, or not even manage, but just get involved in that process at a young age makes it so much easier as an adult, right? Talking about that self-efficacy. And, Dr. Wenzel had already, I thought the picture she put up of the child IBD clinic versus the adult, I'm like, yeah, that's what I'm talking about. Because it's not all the warm and the fuzzies, it's not like, here's some cute little trees and butterflies. It's like, here's a sterile waiting room. So that can be very anxiety provoking. And I think more than anything, especially if a child was diagnosed at a younger age, sometimes their GI doctor has been with them from the beginning of their IBD journey, and the thought of leaving them is petrifying. So there's a lot that goes into that too. Next slide. Okay. Again, time's sake, I feel like there are other things I want to cover that are probably, all these are important. I want to put them in, but this is nice. It's on the NAPScan website, and there's also a great website called Got Transition that I think is a really good resources for people. But it breaks down just from age from like 12 to 14. Here's what someone should be able to do as it relates to IBD. Describing the medical condition, discussing how it affects me on a regular basis. And then honestly, age 12 is not too young to start talking about that transition to adult care. That might seem a little young, but if you think about it, how awful would it feel if a person is 17 and a half and then their GI doctor says, oh, by the way, in 6 months, you need to go to a new doctor. So I think it's good to start that discussion early on. Next slide. And then for mid-adolescence, thinking about, okay, I need to have this MRI, I need to have a scope. What does that do and what's the purpose? At this point, it should be pretty clear what's triggering flares for the person. And then I think more than anything at this age, it's helpful to start seeing your doctor alone for at least part of the visit. Maybe you start together with a parent, maybe, have a little time with the doctor, and then maybe bring the parent back in at the end just to go over, the summary or what was discussed. And then really understanding the choices that a person makes can have pretty significant consequences. So what are the consequences if I don't follow my medical plan? What happens if I start experimenting with alcohol or, weed or whatever? And then also, at this age too, we're thinking about sexuality. I appreciated what Dr. Wenzel brought up too about just the pregnancy piece too. I hope no one's thinking about that at that age, but I bring it up because, teenagers and sexuality, that's an important thing. Next. Okay. Late adolescence. So this is like 17, or almost 18. Start talking about what changes happen when a person turns 18. At this point, I would hope someone knows how to book their own appointments, refill their medicine, contact their team on their own, really being seen independently during appointments. And then really starting, if not having already transitioned to an adult GI specialist. Okay, so again, I don't know what my audience is, but the thing to know is once that magical age of 18, parents can only be involved with your consent. They can't access your medical records. They can't make appointments for you, although I know a lot of offices that still do that anyway. You do want to work with your pediatric gastroenterologist to find and actually schedule an adult doctor. I think more than anything, you want to make sure that your medical records are sent to your new doctor and get a copy for yourself. Oh my goodness, sometimes it takes an act of Congress to get your own medical records. And then there's some cool apps out there too, just to help with this transition and to help you feel a little more organized. So I like Schedule Plus. It's a free app, and you can set reminders, you can share medications list, you can record medications, you can take photos, and everything's in one place. Next. Okay, so this big one, right? I always say college transition and IBD, to tell or not to tell. I think the good thing is that you have complete control over who and when and where you disclose if you have IBD or not. And it really comes down to your comfort level. And sometimes it comes out of necessity too. So if you have a roommate, let's say you have an ostomy and you have your ostomy care stuff in the bathroom, provided it's not a communal bathroom, which would probably be quite a disaster. But these are all things that people need to think about. How much do you want to share with your roommates? And even with friends and being social. I mean, college is like next level social. So remembering that you might need to pace yourself a little bit more. You might feel completely zonked after you have an infusion. These are all things that you need to think about too, because your friends might be like, dude, we're like going out all the time. Why aren't you coming? How do you answer that? So I think thinking about whatever's in your comfort zone is really important prior to getting to college. Partying, the party scene is a big thing in college. Substance abuse. Familiarize yourself with the research. I mean, I can tell you what a lot of the research says about alcohol. I mean, I think it's kind of like a mixed bag. There's nothing super consistent, but then if you're already having a suppressed immune system, if you're, having frequent flares or whatever might be going on, then know what you're doing and know the risks that are involved with making those decisions. Okay, next. Okay, the other thing too to think about with college is just dietary restrictions. And if you're in a dorm room, I mean, some dorms are super fancy now and they have like their little kitchenettes and stuff, but you may have a very limited ability to prepare your own meals. So just thinking proactively about that and even what accommodations you might need going to college. And then if you're having a lot of need for diagnostics or, some of your disease related symptoms, that can get in the way of your studying and your ability to attend class. So it's very important to think about that ahead of time too. Most kids that I work with, if not all of them, have at least a 504 plan in high school. So they're not penalized for missing school, and they have some accommodations to help them feel more comfortable and to level the playing field because, they have a lot more challenges than peers who don't have IBD. But I was a former college professor too. And, we have an Office of Student Disability Services. And if you have your 504 plan, make sure you hold on to a copy of that because you can take it to the Office of Student Disability Services or whatever they call it at your university. And they can actually work with you and even implement some of those accommodations for you so you can be successful. Next. Okay. So I think I'm going to skip this slide and just go straight to the next one with problem solving, another thing that I frequently do with my patients. So I came up with a college scenario. So, when it comes to problem solving, if you really break it down, I mean, a lot of times we do it a lot quicker. But if we think of what it is, the problem is, do I join a fraternity or a sorority? Why not? So when we have a problem, we often brainstorm solutions, and brainstorming doesn't have to be logical. It can be anything. So, maybe you're thinking about, well, I could just join and not say anything about my IBD. I could ask about the time commitment of what I'm facing. You know, I don't have to drink at parties if I don't want to. I can ask about the bathroom situation if I'm living in a fraternity or a sorority house. I could disclose everything about my Crohn's disease or my UC. I could join a house where I know at least one person. Do I even have to live in the house? And then you kind of do like the whole pros and cons thing. Well, if I join, maybe that improves my support system, future connections. I have a bit better social life. If I disclose my health status, maybe they'll be really supportive and then I'll have help available when I need it. The cons of that is a lot of times there is a party culture. Talk about messing with sleep schedule, right? When you're in college anyway, independent of a sorority and a fraternity. If there's mandatory events, am I penalized if I'm hospitalized? You know, if I discuss my health status, I mean, are they going to be unsupportive? So, you know, and then when you just say, all right, here's what I'm going to do, let's do this, see what happens, and then I evaluate how it went. I think maybe that for this person in particular, they want to go through recruitment. And if they're going to pledge, then they're going to say, hey, I have Crohn's disease or I have ulcerative colitis, and see how they react. And if they're jerks, then that's probably an organization I don't want to be part of. Okay. So with respect to knowing if psychological treatment might be right for you, I mean, having a chronic health condition is so hard. And then if there are problems with adherence, if you're genuinely like, oh my gosh, I cannot follow my medical regimen, there are health psychologists that can actually help with that and what are, you know, getting through some of those barriers that are interfering with that. Depression, especially if there are thoughts of suicide or thoughts of self-harm, that would be a really important time to seek out support. Any anxiety related to your medical condition, or even just with all the transitions that happen between the age from like 20 to 25. Oh my goodness, it's such a roller coaster of a time. Health psychologists can help with that transition to adult care. You know, a lot of children's hospitals actually have transition clinics embedded in their hospitals now, which is great. But if not, then there are psychologists who specialize in that can help. And then transitioning to college, the workforce, or even just difficulty coping with medical symptoms. You know, psychologists often have some tools and tricks that can help with pain management that don't involve medication. Next. So some of the best ways to access mental health support. Your primary care physician or your pediatrician may have a whole list of people that they know and trust out in the community. Your GI doctor also, one of my good friends, his name is Dr. Saeed, he said, this is psychogastroenterology, Melanie. And it's true because of that relationship between the brain and the gut. So your GI doctors tend to know psychologists too. The American Board of Professional Psychology can give you people who are board certified in clinical health psychology as well. Your college counseling centers, all of them have great resources. Some of them provide treatment on site, and they also have just some relationships in the community who a lot of those people will provide services for reduced cost for college students as well. Every state, I don't want to say every state, but I would say the majority of states have a state psychological association. I'm actually in Arizona. So the Arizona Psychological Association has a list of psychologists on there. You can search and, you know, filter what you're looking for. You can see who's in network with your insurance company. And then also Psychology Today is a good resource as well. This is fun. These are quizzes that you can take for parents, for adolescents and young adults, and you can see if you're ready for transition. So I thought that's kind of cool to include on here, just so you can go ahead and look at that. And then, you know, for the iPhone too, you can store your medical information. So to wrap things up, transitioning is a marathon, not a sprint. We want to start shifting responsibilities in a developmentally appropriate manner in early adolescence. We want to understand the consequences of poor medical management, plan ahead to help with adaptation to new environments and situations. The goal is always self-efficacy, right? So challenges are things that are supposed to be mastered instead of avoidant. And it's like learning to ride a bike. That's it.
Thank you to all our speakers for their informative presentations. At this time, we'd like to resubmit the 2 questions from the beginning to see how much you've learned. Please make sure your selection to the 2 questions are on your screen now. Again, the first question is, which of the following is a possible reason for transitioning medications as a patient moves from pediatric to adult care? And this is followed by our second question, which age group tends to have the poorest disease management? This is great. The correct answer for our first question is all of the above. We've learned that there are several reasons for transitioning medications such as combination therapy, dose reduction, biosimilars, new IBD therapies, route of administration, and pregnancy considerations. For our second question regarding the age group tends to have the poorest disease management, the correct answer is teenagers. Thank you all for taking the time to participate in these polls. And now let's direct a few of the audience's questions live to our expert presenters. I'd like to welcome Charlotte Rensberger onto camera, who has been answering questions for us throughout the chat. If you have a question for Dr. Wenzel or Dr. Birnbaum or Charlotte, please type it in the Q&A box, which can be found at the lowest part of your screen. So for question 1, it'll be for Dr. Wenzel. When switching to adult care, there's potential for switching up medications as well. If a teen is on an anti-TNF, will they need to stay on this throughout their life? And are there risks to staying on this type of medication?
Yeah, that's a great question. And again, it's a common one that I get when most patients are, at the time of diagnosis. Typically at this point in time, yes, we generally say that if you start on a medication that is working for you and that your disease is in remission, we typically say that you should continue on it. We highlighted some, more recent studies looking at de-escalation or coming off of your anti-TNF medication. And the study suggests that, you will be at a high risk of relapse if you come off of it. So at this point in time, we say if it's controlling your disease well, you should continue on it. I think I saw something in the chat that asked about limitations of life shortening, and the answer is no. Anti-TNF medications are safe to take in the long term, and there is no evidence to suggest that they will shorten your life. And I always highlight that for my patients as well, that you will continue to live a long, healthy life. This, diagnosis does not shorten your life.
Wonderful. Our second question will be for Dr. Birnbaum. Do you have any motivational tips for teen patients that aren't interested in injecting their own medications? Is there anything that parents can do to assist?
There is. So I actually do that quite a bit in practice. One of the things that we do is we break down the steps for the administration, because it's not like, okay, and here we go, just with the injection. So we break down the steps, and then we slowly practice each step together. And what we do is, and again, there are people who help specialize in this, but the more they get involved, usually the less scary it is. But to start, you may just need to do it yourself and then figure out how to distract, and then just gradually work them into the process. But one of the approaches that we do is something called systematic desensitization, and that's exactly what it is. We break it down into smaller steps, and then we kind of get them to participate as their distress goes down, and then with the end goal of them being able to do that independently. I know sometimes it starts with them going into the clinic for that, and a nurse will help, and sometimes psychologists and nurses work together to help decrease that distress and that anxiety.
Wonderful. And our third question, which is open to anyone, at what point should patients start researching adult GI doctors and reaching out? Are they automatically kicked out at 18?
I can speak for in our clinic. We don't routinely just kick patients out. For us, it's really important that we're making that transition at a time that feels safe, both medically, emotionally, and psychosocially. And so, for example, we often will keep our college students through college, just so that we're not transitioning when they're away at college and then transitioning back when they're back from for summer and things like that. Also in our area, it takes about 9 to 10 months to get in with an adult provider. And so if we know that transition is somewhere on the horizon, we start working on it pretty early. It can be, you know, 2 to 3 years in the future, and we start making sure that we are well prepared in every aspect of transition.
And I was going to say too, even with the patients that I work with, a lot of them are out of state for college. So some have chosen to transition their care if they're going to school in a state where the medical care might be really amazing. But if they don't know, then a lot of times their GI doctors will stick with them. And just, you know, they do telehealth or see them when they come home for breaks and work out a way to do that too.
Yeah, we typically do not have an age either at which we, kick our patients out per se. I think it's a little bit provider dependent too, even amongst our IBD providers. I tend to continue seeing my patients through college if they desire, just for less disruption and different providers. And it's a huge, time of transition, as we all know. I think some of it is insurance dependent too. And I've found sometimes families will call and say like they can no longer be seen at a children's hospital. And so sometimes insurance does somewhat dictate time of transition too. So as my patients approach 18, I often encourage them or their families to reach out to their insurance and make sure they can still be seen in a children's hospital setting.
Very helpful. Okay, our next question for Dr. Wenzel. You spoke about pregnancy in women. Are there any fears for male fertility, specifically on medications such as methotrexate and biologics?
Yes, the question was about methotrexate and biologics and male fertility. Is that correct? Yes. So it's a great question. Typically, methotrexate has been shown to affect sperm quality. And so sometimes both, count, morphology, and motility. And so occasionally, anti-TNF biologics have not been shown to affect fertility, nor on the male side, male fertility either. So sometimes when, male patients are thinking about conceiving, again, it's not a common question that we find in the pediatric realm, but it is typically recommended to stop methotrexate like 3 to 4 months before considering conceiving. Again, it's not that you can't conceive while being on methotrexate as a male, and it would not, like if you did decide to continue it, it would not result in any defects to the fetus. It just may affect sperm quality, which then may affect ability for wife or partner to get pregnant.
All right. And our last question, Dr. Wenzel and anyone that wants to contribute, we spoke about combination therapy. Some of our audience has heard about lymphoma risk for young male patients with combination therapy. Could you speak about what age group is in this risk category, and is there anything that mitigates the risk?
Yeah, I can start. So yes, combination therapy has been shown to be more prominent in younger males. Now, younger is a little bit of, it's hard to pin down the exact age range. I think a lot of, studies separate like less than 18 from greater than 18. So if I had to pin a number, when we're saying younger males, we're thinking about more of the teenagers and less of the patients in their 20s, but I would even extend that a little bit into patients in their 20s as well. The risk of lymphoma with like either medication in and of itself is quite low. But those two things together, and it is not just like the combination therapy itself, but it's the time on combination therapy too. We know patients who are on combination therapy for greater than 2 years tend to have a higher risk if it's been being used shorter term, 6 months to a year, to protect the medication and to make sure that you don't develop antibodies, that you continue to maintain a response to the drug. It's generally considered relatively safe because you're not on that combination therapy for a long period of time.
Okay, thank you all. This was a great discussion and we have learned some helpful information today. As our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources. For the teens on this call, be sure to explore our Campus Connection website to learn more about how to effectively manage your IBD. It provides tips for sharing your diagnosis with friends and how to receive accommodations while at college. The IBD Health Center is there to provide information and resources to patients, caregivers, and healthcare providers about inflammatory bowel disease. They're available by phone or email as well as live chat, currently available Monday, Tuesday, and Thursday. If you're looking to connect with other patients and caregivers, the foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. Camp Oasis is the foundation's summer camp available for children grades 2 through 12, where you can connect with others your age and build confidence in managing your IBD. Scan the QR code to see where the camps that near you are. And finally, to watch previous webinars and expert conversations, please visit Crohn'sColitisFoundation.org/MyIBD Learning. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback, and it will help us plan future programming. Thank you to our expert presenters and our IBD community for joining us tonight. Have a great rest of your evening.